physicians and other clinicians to be better advocates for patient access. And since 2006, that's what we've been doing.
And this is great, and it's we and hopefully through this show and other means we can help get this word out, because I don't know that people know that there is such a thing, and I know that there are lots of people today who feel like they're lost in the medical world. I'm one of them, right? And so a little bit about my backstory, and we won't go into there, but it is the same thing, where you do, especially if you start to have some sort of a chronic or severe illness in your life where you need multiple people looking at you, a different diagnosis and stuff. It's a very difficult world to kind of navigate. So how does the AFPA provide some of those services? So if I was somebody who I just woke up this morning and I'm frustrated with the medical care for myself or a loved one, and I said, I need help. I need somebody to help me figure this out because I'm being told, either wait and I'm waiting too long and I'm in misery, or no, and I don't know where to go.
Well, first and foremost, I guess I would encourage listeners to visit the website for the Alliance for Patient Access. On the website, there are tremendous resources available. First, to educate. And so the materials that we produce are in lay language. They're easy to understand. Our goal, if it's a complex issue, is to break it down into easy to understand materials. And the materials that we produce are quite varied. We produce a number of videos, 2 to 4, maybe 5-minute segments that take a complex issue, break it down into easy to understand language. A lot of people enjoy learning via video today. But we also have policy papers. These are more in-depth pieces. We have, quick fact pieces. We have infographics, and they cover a range of topics and what utilization management techniques are being forced onto patients and their physicians. And so first is, education. And then second, it would be to, with your physician, to point them to the Alliance for Patient Access, because they would also have access to these resources and potentially others, and could even join us in some of our training sessions, such that they can become more effective advocates with their patients.
Yeah, that's great. I mean, I spent some time on the website, and you're right, there are some amazing resources. So I would encourage anybody who's listening, who's got that situation, or a friend or somebody, but definitely go to the website, and we'll put the link on the post on the Heroes of Healthcare podcast website. So people can, if you don't remember it, you can go to our website and find the link. Or I think if you just Google the Alliance for Patient Advocacy, it'll come right up. So encourage.
Alliance for Patient Access, and it'll come up.
Patient Access, excuse me. People will find that resource. If you can, tell us a little bit about, give us some examples of some of the areas that, you got where you guys have seen success. Like you said, you've been around since 2006. You've obviously done a lot in terms of moving legislation medically in states, getting insurance companies to change policies and stuff. But where have you seen more of the impact on the patient side?
Well, I could give a couple of examples. One, let's take up the idea of non-medical switching. Let me first define that. Non-medical switching is when you and your doctor have finally found a medication that helps your condition. Doesn't matter what the condition is. Let's say you've tried a couple of things and you finally found the right medication, the right dose, and it's helping, and you're stable. Non-medical switching is when your health plan says, well, we understand all that, but you're going to switch to this medication going forward. And they have several ways they can do that. One is they just take your medication off the formulary and say, we don't cover that medicine anymore. And you can have this other one. It's not a generic that we're talking about. We're talking about a completely different medicine that they're switching the person to. Or they could do this. They could say, your medicine is still on the formulary, but we're placing it on a specialty tier. Therefore, your copay is going to be 10 times what it currently is. Now, if you switch to this other medicine, your copay will only be $5. It's your choice, but what are they doing there? So let's understand what's happening when they do non-medical switching that way. What they're saying is that for those in our health plan that can afford the higher copay, they can get the medicine that's already helping them, that their physician and that they found and it's working, and they can continue it. And for those that don't have those financial resources, too bad. You're not getting the medicine any longer because you can't afford it. And so these utilization management techniques are abusive. And the reason I say that is because they disproportionately affect those that have socioeconomic challenges, right? Who's not going to get the medicine? Right? You can figure that out quite easily. And so therein lies the problem. Okay, so I'll give an example. There's a health plan that said everyone that's getting this treatment for a certain type of headache, it was a neurotoxin injection. You're getting this neurotoxin injection, and the neurotoxin that you're getting is FDA approved for the exact kind of headache you have. We're no longer going to let you have that neurotoxin. You're going to have to be treated with this other neurotoxin. So this non-medical switching idea. But here's the issue. The other neurotoxin was not FDA approved for the problem that the patient's being treated for. So the health plan says, we don't care. We don't care. Your choice is this. You don't get the medicine at all, or you're going to take the one we tell you you're going to take, even though we're forcing you and your physician to use the medication off label when you're already established on one that's working for you that is FDA approved for your condition. Okay, we fought that and had success in getting the health plan to back off from something so egregious in its approach.
So sometimes, I want to be careful because I don't want to, without representation of the insurance industry, I don't want to overreach. But when we hear stories like that, and Dr. Charles, we hear it over and over again. When we hear stories about that, what can, and I'm not saying this very well. It seems to be like it's a constant battle. In other words, the minute you fixed that one example that you just gave us, the insurance companies are changing the rules on 5 other ones, maybe not even related to your specialty or whatever, but it's always this kind of, moving target that we're trying to hit. And this is where sometimes people ask me, is the healthcare industry irreparably broken? And there are times when I say, yeah, I think so, but I don't know. How do we get our arms where that isn't happening? The picture of the insurance is a couple of maniacal guys sitting in a room and they just sit there. There's an old British thing where the person hits the computer and says, the computer says no. And just that's their answer to everything. The computer says no, right? I'm not making any decisions. We just say no and hope you go away. Maybe that is the dynamic that's going on there. And but is there a way for us to fight this on a broader schedule instead of trying to,
Well, so the answer to that is yes. And that's exactly at the core of the Alliance for Patient Access. We, as I was saying before, we would like to help physicians, instead of battling one patient at a time, to battle to change policy. And so to work at a policy level. So if you ask me this question, is the American healthcare system broken? I would say definitely not. I've had the opportunity to live and work in a healthcare system, a single payer system in Europe, and everything has its pluses and minuses. But I can tell you from my personal experience, we do not want that system. It is not better. There are policy people in the U.S. that say, "Oh, it's better," and the pasture's always greener on the other side. But having lived and worked in that system, and having just had dinner with friends who live in the UK last week, that just bemoaning the healthcare system, the National Healthcare Service in the UK, and the wait times that they have and the lack of access to new and exciting therapies is staggering. So when someone tells you, oh, it's so much better over there, you need to take that with a grain of salt. So that's
Yeah, no, and I agree. And I experienced that. I had a business of my own for several years up in Canada, and same thing. People. I'd have somebody who said, "I have to take my son to the doctor this morning. I'm going to be out," and I'm saying, "Out? Aren't you going to just go see the doctor and be back in at lunch?" And they'd say, "Oh no, I'll be waiting there all day." And I'd say, "What do you mean you're waiting there all day?" She said, "Oh no, I'll be lucky if I get out of there by 10 o'clock tonight." So yeah, the grass is always greener. And I recognize that. But is there something on a broader basis that we can do? Is there, I know it's the whole capital and the lobbyists and stuff, but how do we get our arms around the insurance companies from just kind of saying no to stuff that doesn't make sense to say no? Is that we don't have enough time for that answer, or is that a big one?
To be sure, and take a balanced approach, right? If you're looking at it from a societal perspective, there's only so much funds available for healthcare, right? So it's not wrong, in our opinion, for there to be utilization management of healthcare resources. We should manage all of our resources. The Department of Defense, healthcare, and education. We should manage all of our resources, right? That's good practice. We would be foolish not to. And so utilization management is appropriate. What we're pushing back on, and what sometimes feels like whack-a-mole when you get one problem solved, another one pops up somewhere else, is these practices when they become abusive, right? That's where we want to step in and say, wait a minute. Can I give you another example? Copay accumulators. Many people haven't heard of this one, but have you ever been to your physician and you're getting a new medication and there's a copay coupon? It's a coupon you can use to help cover your out-of-pocket, your deductible for the medicine to make it affordable. And it's just so you can try it, right? It's going to see if this medicine is good for you. Here's a copay coupon to reduce your out-of-pocket, and let's see how it works for you. Well, some insurance plans started what they would call a copay accumulator program. And what that would do is they would say, okay, so if your copay coupon was good for $1,000 a quarter, for the first year, and the coupon paid $4,000, because you needed this very expensive medicine, and it helped make it possible. At the end of the year, when you think you've paid $4,000 towards your out-of-pocket for your health plan, oh, no. What the health plan was doing was saying, we're not counting that towards your deductible. So the health plan was taking the $4,000 from the coupon, and then they made the patient pay the $4,000 again. So they were double dipping on people. Well, okay, so several states were like, wait. And so this was one of the battles at the state that just, didn't take long, right? Because that's not only abusive, that sounds criminal. And so many states passed laws. And I think once you hit a tipping point, when about 15 to 20 states pass a law addressing an issue, the large health plans will be like, okay, all right, and they'll abandon that, abusive practice. You're right. Yeah.
Right. We don't want to go to court. We don't want to go to court 35 more times. So let's just adopt the policy. Right. Yeah. You get a sense of critical mass.
You think if you have to pass something at the state level, you've got to get it through all 50 states? It doesn't really work that way. There was one on epilepsy medications where, they were changing a generic every month on patients, and so after a critical mass of states passed it, then the health plans quit fighting it.
Became kind of common law sort of a thing. So as we're kind of coming up on time, talk to me a little bit about what are some of the big initiatives for the AFPA currently? What are you guys currently working on? And what does your charter look like for the next several years?
If you visit the website, you'll see that we have a number of physician working groups. And I think that really gives you an idea of our focus. The physician working groups are focused in biologics and hepatitis, obesity, cardiovascular disease, mental health, oncology, respiratory, diabetes, neurological, and then we even have another one on rare diseases. Here, these working groups really mirror where amazing innovations are occurring in medicine. I mean, for me as a physician, what a great time to be a physician because we have so many amazing medicines coming to market, biologics for cancer and such. And so you'll see us focused in ensuring that patients have access to these new medications and sometimes curative treatments when they become available.
Yeah, that's great. I mean, we've highlighted several this year on the show and some of the amazing innovations that are coming and due to technology and AI and operational efficiencies and things. I continue to be amazed by the company in Scotland that's 3D printing cancer cells. So you start thinking it's a little Star Trek or Star Wars type stuff, but it is here and it is happening. So I agree with you. It is an interesting time for us to be in medicine and see how we can continue to apply those things. So, well, I thank you for your work. Obviously, it's not new work, but it's been a passion of yours for quite some time. And I really hope that not only patients take advantage of the materials that the AFPA is offering, but the physicians do too, as you said, and they can see where they may find resources that they were not aware that were available and things of that nature. Is there a
And then finally, the policymakers and their staff,
Oh,
we
yeah.
have found these to be terrifically helpful.
100%, right? And that's being able to do the debate on both sides, right? As you said, those really good orators who came in, they understood the other side too. So here's an opportunity to do that. So thank you for that service, and we continue to let us know how we can help support the AFPA and get your word out and make sure that more people are aware of the services and can take advantage of them.
Well, Ted, thank you for inviting me to join you. I've really enjoyed our conversation.
Thanks. And my normal last question is that I have on the podcast is, so who was your hero, either growing up, currently, both?
I'd say in medicine that two come to mind. The first one is a fellow named Riley Reese. Riley Reese is a plastic surgeon. And when I was an undergraduate, I had the opportunity to work in his laboratory as a work study student. It was part of my financial aid, and he hired me to wash laboratory dishes, beakers, and things like that, after hours. And over the years, became a mentor. And I had no interest in going into medicine when I started college at Vanderbilt, but he took me on rounds with him one afternoon, and then from there, an interest grew. The second would be Jerry Finishell, who was the first and founding chair of the Department of Neurology at Vanderbilt. And Dr. Finishell mentored me and was a hero of mine from the time I was a third-year medical student to serving with him on the faculty here at Vanderbilt. He just had this exceptional ability to be a friend, a mentor, and a counselor. And he understood the difference in all three. And he could play all three roles very well and understood the boundaries and was just incredibly effective. Just a wonderful person.
It's good. We need those mentors. We need to be mentors. We need to continue to do that and continue to pour into the next generation. So I love that you had two good ones that helped you. I often say I had my real parents who taught me life and my professional parents who taught me my career, and lots of good influences there. So,
well, the first one, Riley Reese, gave me a wonderful gift. As he was leaving Vanderbilt and I was headed off to medical school, I gave him a gift. He was an avid sportsman, and I had a gift for him. And he sat me down and he told me he wanted to give me a gift. And he said, "Here's the gift I'm going to give you." He said, you obviously appreciate, the time that we've had together and the relationship. He said, "I'm going to challenge you to identify young people in the future and invest your time in mentoring them towards success." And I took that to heart. And it turns out it's probably the most rewarding thing that I've done in my career. In my 40 years at Vanderbilt, the opportunity to identify young people, taking his gift, his challenge to heart, and mentoring young people toward their goals, their careers, many of them obviously toward medicine, has brought me more joy than I could have ever imagined when he gave me that gift.
That's great. Yep. Love that. Pay it forward is always a great message. So, well, again, Dr. Charles, thanks for all your great work, and please keep going. And if we can be of any support here, please give us a call. Love to have you back on the show and continue to talk about the great work that you're doing.
You've been listening to Heroes of Healthcare. If you enjoyed today's episode, please tell a friend or leave us a review wherever you get your podcasts. You can also visit us at www.heroesofhealthcarepodcast.com for more information or to listen to past episodes. Thanks again to our sponsor, Jackson & Coker Locum Tenens, providing interim physicians and advanced practice staff for over 40 years.